Okay, well, it's now 3:01 here at Central Time, and I want to make sure to be respectful of everyone's time who took time out of their busy days, clinics, work schedules, personal lives to spend this time with us to hear a little bit more about what we're doing as part of the Government Relations and Economics Committee of ACRO. So thank you for joining us. First of all, I'd like to introduce everyone else who is on the committee and part of our team here today. Again, my name is Tarita Thomas, and I'm the chair of the GREC. I'm here with Dr. Dwight Heron, who was the prior GREC chair and now the president of ACRO, and as well as Dr. Chris Jahraus, who is our vice chair of the GREC, and Dr. Wilding, who is one of our GREC fellows, and then Jason McKitrick, who is our support through the efforts we're trying to do with health policy, who's with Liberty Partners. So thank you again for all being here, and thank you to all of our town hall members for being on this call. I have an outline. If we can just share that. Can you all see the screen? Thumbs up or thumbs down? Very good. Okay, so thank you for sharing that, and we can just move on to the next slide, which is going to be our outline for today. So I've introduced all the members of the town hall, and our meeting today is about an hour, and we want to spend it in 3 different sections. One, talking a little bit about the physician fee schedule, then talking a little bit about radiation oncology payment reform, and finally, leaving a good part of the meeting to open questions from all of you who've taken the time to be here with us. We'd really like to hear from you and what your questions, concerns are. While we're going through this presentation, just to keep the flow going, if you have questions that come to mind, please feel free to put them in the chat, and we can address them either at the end of the meeting, or if we don't get to all of them, after the meeting, if we can, with emails and that. So I'd like to hand it over to Jason now for the start of the discussion. Thanks.
Thanks, Dr. Thomas. Dr. Thomas laid out, I think two of the really big things that the radiation oncology community and frankly the entire physician fee schedule community is going to be concerned about over the next couple of years. One does relate to, I think, some of the near-term challenges, as well as the potentially broader reform efforts that are going to happen maybe next year. And the second, as Dr. Thomas mentioned, relates to radiation oncology payment reform generally, and some signals that CMS had sent in last year's final rule. So taking those in order, Fraser, if you could please go to the next slide. And then one after that, we're going to talk a little bit about the physician fee schedule first, and just to kind of level set that, the physician fee schedule is really made up of 2 components. It's made up of the conversion factor and and relative value units. And so the conversion factor times relative value units are literally what you are paid under the physician fee schedule. And while the relative value units aim to account for, again, the relative value of any service that's provided, the conversion factor puts a dollar figure on that. And both of those things are challenges that we face over the course of the next couple of years. There's a bill, HR 2474, that the AMA has been championing, that of course ACRO supports, that would deal with the shortfalls in the conversion factor by finally tying the conversion factor to MEI in a way that is appropriate. The second bill, HR 3674, is a bill that would deal with the RVU side of the equation. And we have a couple charts that kind of lay that out. So Fraser, if you go to the next slide, please. On the HR 2474, as you see, what you've got there in that green line is practice costs. And you can see that going back a couple decades, that practice costs have far exceeded what's in that black line, that physician update. That's the physician fee schedule. Some of their sites of service have grown faster than practice costs, but again, the physician fee schedule has not. And so what HR 2474 intends to do is stop that widening shortfall that is disadvantaging all physicians and all sites of service. But if you go to the next slide, Fraser, what you see is that HR 3674, another bill that ACRO supports, it relates to the RVU side of the equation, and it shows you that again, within that black line that was in the prior chart, which is an average, what has been happening is that it's really your specialists that have been hit: radiation oncology, vascular surgery, interventional radiology, et cetera. And in particular, the folks that are in the freestanding settings have been really harmed by these redistributions within the PFS. You've seen other folks on the other end of the chart have been conversely been doing much better in recent years. And it does speak to that sort of area that is sort of highlighted in that circle. If you go to the next slide, it does speak to, we believe, what is the asymmetry in the physician fee schedule. And these were actually not our words, but Dr. Jahraus' words, MedPAC chair, and we had a meeting with him over the summer, and we were talking to him about these issues, and he mentioned this asymmetry, and I think this is not something that is well understood, but I think is something that we need to talk a little bit more about, and that is that when you think about the physician fee schedule, I think the average person just kind of thinks, okay, it's just how doctors are reimbursed. It just pays for their professional fees and all sites of service. And while it does that, it doesn't only do that. What it also has in it are the technical payments just in the office-based setting. So it really is, particularly when you think about the high-tech, high-cost equipment and supplies that the specialists handle, it really is kind of a mismatch within the PFS. It's kind of a Frankenstein's monster that was there in its creation in '92, but I don't think that the creators, and I've talked to former CMS staff about this, I don't think they contemplated that the office-based setting would be able to do the minimally invasive kinds of things that we can now do with this amazing technology. And so, when you see the budget neutralizing that has happened over the course of the last many years, that is why this asymmetry is why you've seen, I think, what you've seen with the office-based specialists in particular being disadvantaged. So going to the next slide. Again, the state of play with HR 2474, a bill to fix the conversion factor, what we're dealing with in this final rule is roughly a 3.4% cut to the conversion factor. There are various bills in the Congress. The big one, again, is the AMA bill to add an inflation adjustment to the physician fee schedule long term, given that Congress has already built in, based on last year's bill, a 1.25% increase. That would mean another 1.25% would be 2.5%, which is what is predicted for MEI next year. And that is reflected in the Senate Finance Committee package that was voted on last week. You just today saw in the House Energy and Commerce Committee, they have considered a smaller provision that deals with conversion factor and sort of exempting more of the services that are subject to budget neutrality, but it's very, frankly, in the grand scheme of things, is not a lot, and does not move the dial nearly like 2474 does, and the direction that we think it needs to be done. There is also an effort by the so-called G2211 coalition, which is a coalition to stop the implementation of the primary care code in 2024. We understand that effort is probably not going to be considered in any legislation at the end of this year. And I think on timing, that is an important point. And that is that I think folks should be prepared. We don't know this for sure, but there are a lot of questions about whether or not there's going to be an end of the year package at all, given how the House seems to have positioned itself to try to kick the spending into the third week in January of 2024. So I think folks should be prepared for this. I'm not saying it's going to happen. I'm not saying that we can't get this Medicare package done before the end of the year, but it is something I did want to make folks aware of. If you go to the next slide, again, the sort of update on HR 3674. There was an amendment offered by Senator Tillis in the Senate Finance Committee markup. It was a file-only amendment. But it was an amendment that effectively was put in Tillis, on notice that hey, he wants to work on this provision with Senator Crapo, Senator Wyden. On the House side, Energy and Commerce, again, as I mentioned, had a markup as well. There was an offer and withdraw by Congressman Bilirakis and Congressman Cardenas. They're the co-leads on the bill. And there was an agreement between Congressman Bilirakis and the Health Subcommittee Chair Guthrie to work on this. And again, we'll see. I think this is in the state of play, along with the other broader conversion factor issues that are under discussion. If you go to the next slide, again, what that bill 3674 does is, it would stop the remainder of the so-called clinical labor cuts that have cut some of the services, that we and others care about 10-15% more in the 2022 PFS. Those cuts have been phased in through 2025, so those cuts are ongoing. And it's something that ACRO and the broader clinical labor coalition, a number of other specialties support. The device trade groups all support it as well. So again, conversion factor, RVUs, both issues that we're working to address. And I think next year could potentially be a very big Medicare bill. We've been starting to hear that from staff on the Hill. And when you think about the lame duck next year, we think there's the potential for some significant legislation. There's a lot of discussion at the Senate Finance Committee markup last week from senators saying we gotta fix this PFS once and for all. So we'll see how that pans out. The other really big issue that Dr. Thomas mentioned was as it relates to radiation oncology payment reform. And I'm putting in the chat here. And if you go to the next slide, just to transition this a bit, Fraser, in the 2023 PFS final rule, CMS, these are CMS's words that, they're saying that because a radiation oncology model was not finalized, CMS is saying we're going to take a look at adopting the CPT code set that was sort of in play for the 2015 PFS. The reason that's concerning, of course, is that, based on the information we had back at the time, those cuts could have led to significant payment reductions. And so it's why when that started to happen, there was a lot of interest to see what we could do to not have that happen. There were some current concerns on CMS's side as well, laid out in the 2015 PFS. If you go to the next slide, Fraser, where CMS was saying we've got some concerns, substantial nature of this code revision. We're going to delay reevaluation of these codes until 2016. And so they put, instead of the predecessor codes, the 774XX codes, they put in place some G codes for these treatment delivery and imaging codes. If you go to the next slide, they continued doing that in the 2016 PFS based on comments from stakeholders. And then in the end of, so that 2016 PFS was a 2015, done in 2015. At the very end of 2015, you saw PAMPA. And that's the next slide. And what you saw in PAMPA, the Patient Access and Medicare Protection Act. Thanks, Fraser. What you saw on the next slide was a freeze, as folks will recall, to those G codes. In the Bipartisan Budget Act 2018, that freeze was extended for another year. And ACRO and other specialties, of course, began consulting with CMS about model design considerations. Part of the reason, of course, we continued to be concerned was as we looked towards the end of the freeze, and what would have been the 2019 PFS proposed rule. We did another subsequent analysis. Next slide, Fraser, please. That implementing that 2015 code set would have resulted in a 40% cut to simple IMRT. And that's, I think, why the discussion about an APM was so important, because CMS did not implement that for a number of years while this APM was under discussion. And if you go to the next slide, if you see their comment in the 2019 PFS final rule, they say that, we think radiation oncology is a promising area of healthcare for bundle payments based on the findings of the report to Congress that was directed vis-a-vis PAMPA. So for a number of years, that new code set didn't happen. And there was, a lot of discussion about various elements of the CMMI's radiation oncology APM model. When it started to come down to some, critical discussion points as it relates to the model and the savings that CMMI said they had to get from CMS OAC, that's the Office of the Actuary. What it was starting to come down to was if you go to, there we go. I'm sorry, the next slide. Thanks. Was basically CMMI saying, look, we can either, lower the discount, but if we lower the discount, we're going to have a higher geographical area. So ACRO went on record, said, look, we'll be okay with the 40% instead of the 30% geographic area if you would just lower that discount to something that's reasonable, maybe something consistent with the oncology care model. And so was kind of where we were. And part of the reason that we were saying that, if you go to the next slide, was again the really substantial pressure that the freestanding radiation oncology had been under for a number of years. We see it in the data, where 76% was private practice in 2002. It's shrunk considerably. And what that means for particularly in rural areas and folks' access to radiation therapy treatments, we think it's not great policy to keep shutting these centers down. And so I think that kind of tees us up to today and some reviews that the team over here has been doing vis-a-vis the rocker model. And Tarita, I'll hand it off to you to talk about that in a little bit more detail.
Thank you, Jason. I'm just trying to start my video. So let me just try to do that. So Fraser, maybe you could help me out with the video, and as we're doing that, so I can be seen on the screen. I just want to thank Jason. Thank you for that background. Okay, that's been very helpful. And I think gives everyone a good overview of what we've been through so far in terms of policy for radiation. And it brings us to the most recent developments on radiation oncology alternative payment models. Fraser, if you could please, start my video. Okay, good. So there, thank you. Thank you, Fraser, for starting that. And if you can just please also go to the next slide. And I'll just keep talking. As people may be aware, last year, the Center of Medicare and Medicaid Innovation said that they would delay the RO model to a date that was to be determined through future rulemaking, as Jason had alluded to, which effectively meant that the model was dead. And in stating this, CMMI noted that there were some parties that will not support the RO model moving forward with unchanged discounts, and that these parties have also requested that we not increase the geographic scope of the model. And as Jason mentioned on the previous slide, ACRO was willing to increase the geographic scope if CMMI was willing to lower the discount. As people are aware as well, that ASTRO has released the parameters of the radiation oncology case rate model. And ASTRO was kind enough to help us to put together this very high level side-by-side of Rocker and CMMI's RO alternative payment model. And in many ways, they are similar. I just want to highlight a few things for us as we continue our discussion. Both models utilize a case rate system for 15 of the most common cancer conditions, which comprise about 85% of total cases that we see. Both models have a similar number of exclusions, although Rocker also excludes proton therapy. Both models save roughly the same amount over 5 years. There are some differences though. Rocker, there are no withholds, and Rocker uses accreditation instead of quality measures. Also is requesting 100% participation of Medicare providers, and a net lower discount due to built-in inflation updates for Rocker. Now, we are by no means experts on Rocker, which is really an ASTRO plan, and we continue to try to understand it as best as we can in terms of trying to help to move our field forward. But from our vantage point, we do see enough similarities between Rocker and CMMI's approach that we believe broad consensus is possible on radiation oncology payment reform. So I wanted to just move on to Dr. Wilding, now sharing a little bit about the survey that he's been working on. So I'm going to mute.
Thanks, Dr. Thomas. So to that end, ACRO is in the process of conducting a survey on radiation oncology payment reform in the hopes of informing the broader community about stakeholder preferences. As response collection is ongoing, there was concern that discussion of preliminary results today could influence future survey participants in a manner that could bias results. Therefore, today we will simply provide an overview of our efforts with this survey. Next slide, please. So with this survey, we aim to provide all radiation oncology physicians, both attending and residents, an opportunity to anonymously and efficiently share their opinions. We hope that doing so will promote both transparency and also help facilitate further dialogue. Next slide, please. So the survey was sent to radiation oncology attending and residents based on data from the AMA and ACRO. We've had a pretty good response so far. This slide's a little outdated. We actually have more than 350 responses collected so far. Next slide, please. So we hope to obtain data that represents broad perspectives, diverse data from within our field. Fortunately, we're already seeing that play out with the responses we've received. In addition to describing participant characteristics, obtaining demographic data within our survey will help us delve into the perspectives of various subgroups within our field. This will allow us to better understand not just collective viewpoints of our field as a whole, but also nuances where different viewpoints are most prevalent. So you can see some of the demographic information we're collecting there, just high level, experience level, academic versus community and private, hospital-based versus freestanding facilities, practice setting, urban, rural, etc., size, location, and such. Next slide, please. So our survey questions at a high level ask about radiation oncology physicians' opinions towards episode-based or case rate payments, site-neutral payments. We ask people to share their opinions on various exclusions within the models we've seen proposed, how affecting payment based on accreditation status is viewed as well. In addition to viewpoints specific to payment models, we've also invited physicians to share their opinions on direct supervision. Next slide, please. So I hope that everyone on this call will share their opinions through the survey. I invite and encourage your colleagues to do the same. It's likely that every physician here has a link to participate in the survey already in your inbox. If you haven't seen it, I encourage you to search your inbox for the term payment reform survey. Many email filters have unfortunately hidden the survey in junk folders. We are making a genuine effort to give every interested physician an opportunity to complete our survey. Of course, some of the email data we have is outdated and some email servers block the survey altogether. For that reason, we've created a form where you can submit an updated email address for us to direct the survey to. So the link to that form as well as the QR code for it is on your screen. I'll also share it in the chat momentarily. For physicians who want to enter an updated email address, we've had better luck with the survey reaching individuals' personal email accounts as opposed to those managed by institutions. For that reason, I encourage those who complete the form to consider sharing their personal email account. We'll keep it confidential and use it only for survey distribution. With that, I turn it back over to Dr. Thomas to moderate the next portion of our town hall. Thank you.
Okay, thank you. Thank you, Dr. Wilding, and thank you again, Jason, and everyone who is on the call now. You know, we wanted to leave enough time for questions or thoughts that we can share as a group with each other and really try to learn from each other to try to move our this whole process of payment reform forward. So if anyone has a question, please just raise your hand using the function in the Zoom program. So we'll wait for a couple of, just for a minute or so. I do have a couple of questions that I can try to help stimulate the discussion, but let me just give it a couple more minutes to see if anyone's hands are raised. And it's just so encouraging to see so many of you here on the call with us today. I think that just speaks volumes about how important these issues are to all of us, no matter our practice environment. You know, what our role is in terms of in radiation oncology. So let me just start by throwing this question out to the whole panel here. You know, there are questions that have been asked regarding this asymmetry that Jason spoke about in terms of the physician fee schedule and how we are potentially going to address this and apply this in terms of radiation oncology. So if anyone would like to try to address that question.
Well, so Tarita, yeah, I mean, I think what is interesting is that the AMA for 10 years, at least, I think at this point, has been actively telling CMS that they'd like to see the high cost disposable supplies over $500 pulled out of the physician fee schedule. And I think they've been saying that because again of this asymmetry relativity issue, that it's you know, kind of they don't belong. I think there's an argument to be made that the high cost equipment similarly, you can say over $500,000, I guess, in the case of high cost equipment, similarly doesn't fit well. If you go to a freestanding radiation oncology center, if you go to a freestanding limb salvage center, vascular access center, these centers look an awful lot like a facility. I mean, they look like a hospital or an ASC. So I think that's one, way we might think about this asymmetry and how it might, in our case, apply to radiation oncology.
And Jason, to that point, I mean, I think you made it, and maybe it may have gotten past a few folks earlier, that, if you think about the physician fee schedule when it was created, we've had this conversation before, a lot of the things that we do in the freestanding setting was unimaginable at the time that fee schedule was created. So the complex things, and you just said it, if you look at a facility, a freestanding facility, in many ways, they look like a hospital, right? So, and we're doing a lot of those things there, but the cost associated with those supplies are sort of bundled essentially together in the freestanding, as opposed to what happens in a facility where you do have a separation between the technical and professional. You want to maybe clarify that a little bit more?
Yeah, I mean, I think Fraser, if you want to maybe go back to one of our earlier slides, slide 7. It's helpful to look at that chart. If you're not able to do that, let me know, Fraser. Fraser, can you hear me?
I can, bear with me. I was
Okay.
just getting to that proper slide.
Okay. So, what is, again, interesting about the different, I mean, these are the major fee schedules, right? If you're, they're not all of them, but typically you're thinking about either inpatient hospital, outpatient hospital, ASC, or a physician office. And, there's a lot weird about the physician office. First of all, when you talk to some staff members on the Hill, they think an office is, kind of like the office I'm sitting in, with you got a chair and a desk and a lamp, and that's your office. And as we know, and as Dr. Heron mentioned, a physician office can be much more than that and look like a wing of a hospital. So what is interesting about those other fee schedules is those are technical only. So your linear accelerator in a hospital outpatient setting, that's the technical part that goes through the HOPS fee schedule. But if you are doing the same thing in a freestanding, that LINAC, that's in the technical within the physician fee schedule. And so as policymakers trying to make efforts to increase payments, for all physicians, but as we know, in particular, there's been a really significant push by MedPAC and others to put more money into primary care. And what happens is when you budget neutralize that, of course, the things that are getting squeezed the most are those high-tech equipment and supplies. And the clinical labor update is just the most recent example. This has been happening for years. But the clinical labor update is a great example of that data was from 2002, and for clinical labor, and what that is it's CMS's way to, in their minds, way to compensate doctors for their nurses, or in our case, the radiation therapists, of course. Do doctors wait for CMS to update those values in the physician fee schedule? Of course not. Nurses and radiation therapists have been getting pay raises, since 2002, of course. But when they updated that in the 2022 physician fee schedule, updated that for the salaries, everybody should have gotten an update. Everybody, including radiation oncology and all these other, office-based specialists I'm mentioning. But because of, again, this budget neutrality issue, what happened was a roughly 15% cut to G6015 in the 2022 PFS. And so, again, CMS is phasing that in through 2025, but this asymmetry, Dr. Heron, as you're mentioning, there is an asymmetry, and as we think about physician fee schedule reform broadly, we do think that addressing that asymmetry somehow might be a way to move the ball forward.
Jason, I think the other point is that the magnitude of the asymmetry is just something that a lot of us don't realize. I didn't until I went and tried to look at it as we were preparing for some of our recent Washington visits. And if you look at the G6015, our code for IMRT as freestanding centers versus, and somebody correct me if I'm wrong, I think it's 77385 for inpatient or hospital outpatient setting rather. The difference is about 50% higher in the hospital setting. And, even if you account for the fact that image guidance is not permitted under the hospital schedule, the difference is still 25%. And yet we pay the same, if not occasionally more, for our equipment than do hospitals. And so I think that just emphasizes the critical nature of moving towards site neutrality and of just remedying these issues that you've described very eloquently.
Great. I'm sorry, Jason, I think we have a question. I think you're probably the best positioned, and maybe Tarita, you want to chime in on this, given our recent advocacy work on the Hill. But the question from the audience is, could you speak to how HR 2474 is being received, presumably on the Hill, and the likelihood that it'll be included in legislation this year?
Yeah, happy to. I did speak about that briefly, but it's definitely worth diving into. So again, physician payments are conversion factor times RVUs. The HR 3674 deals with the RVU portion of the equation, but HR 2474 deals with that conversion factor side of the equation. And that bill, again, as frankly common sense as it is, and Fraser, if you want to bring up slide 5 again for folks to give them some context, as you see there, if 2474 is not enacted, this gap is going to keep widening between that green line and that black line, that practice cost and that physician update line, which is untenable. Of course it's untenable. The issue, of course, though, with 2474 is that our fiscal house is a disaster, and it would be, from a congressional budget office perspective, it would be a massive coster. I haven't seen a score, but I'd imagine it would be tens of billions, if not $100 billion in terms of trying to fix that. So to answer your question, will 2474 as it is be enacted in the short term, in Q4 this year, Q1 of this year? I don't think so. It's just too much. But I do think that when you listen to those senators at that Senate Finance Committee markup last week talking about this stuff, it does just feel to me that they're thinking lame duck next year, that they're going to get. It just feels that way. I can't promise you, but I think if anything big along the lines of 2474 is enacted, it'll be lame duck of next year. Now, having said that, I do think they are starting to lean into 2474, and as I mentioned, the Senate Finance Committee markup contains a 1.25% update to the conversion factor, that the Senate Finance package that passed out of Senate Finance Committee. So that committee in the Senate is on record as saying, yeah, doctors should get a 1.25% increase on top of the 1.25% increase that was already in the law based on what Congress passed last year. So when you put those two things together, that's a 2.5% increase to the conversion factor relative to what it would otherwise be. That's MEI, that is the Medicare Economic Index, that is an inflation update. So you're effectively getting for 2024 sort of a down payment, if you will, on 2474 long term. So a lot of other things way above anybody, his pay grade in terms of, how many more speakers we're going to have between now and the end of next year, those kinds of things. But, I do think that Congress is starting to lean into that a little bit. Now, on the House side, as I mentioned in Energy and Commerce, there's another bill, a so-called Doctors Caucus bill, that is much more narrow in scope. I think that is frankly, they're sort of trying to be consistent with their own caucus in terms of spending and telegraphing towards the November elections next year. So it's much more narrow. And what all that does is it changes the exemption from budget neutrality, which currently, and this may be surprising to some folks to hear this, there actually is a very small exemption to budget neutrality currently. It's $20 million, which in the grand scheme of a roughly $90 billion PFS is nothing, right? So they would increase that exemption from budget neutrality from 20 to 53 million starting in 2025, I believe. So really not much to move the dial, as I mentioned, but it is something to be aware of, and they may do something. You can imagine that in some bigger package that they might do a little bit of both. Maybe they'll do a little bit of 2474. Maybe they'll do a little bit of exempting services from budget neutrality. But that is something, again, for you to be aware of, Dr. Spraker.
Thank you, Jason and Dr. Spraker, for bringing up that question. I just wanted to make just a comment on Dr. Jahraus's comment. I think it's really important how he described the differences depending on site of service. And, some people may say that, a lot of us are now employed radiation oncologists, but I feel my opinion is that I think it's important for us to look to make sure that we can cover all our patients' needs across the different sites of service, meaning either standalone free centers or a hospital-based outpatient center. So we have some great questions coming in. Todd's question is to potentially speak to the growing portion of Medicare patients becoming Medicare Advantage and how this trend is growing, and how much will this affect the legislative fix, if possible.
So I actually was just in another meeting today, and we were talking about this very question. And I think that in terms of how much a legislative fix can help, I think there's maybe not as much legislative fix coming on this as there is some regulatory fixes coming on this. There is an increasing amount of distaste for the idea of paying participants in Medicare Advantage programs to take on their particular product. So insurance company XYZ saying, we're going to add X amount of dollars to your monthly income if you take our product, and even zero copay or zero monthly rates. I'm blanking on the proper word. Are being scrutinized fairly heavily. So from that standpoint, I think there's good news coming from a regulatory standpoint. In terms of legislative, maybe one of the others of you can comment on that.
Just briefly. So although, we're seeing a trend towards more Medicare eligible people going to Medicare Advantage, slightly more than half of eligible enrollees are in Medicare Advantage now. traditional Medicare is still, such an outsized payer that what they do has, rippling effects through, Medicare Advantage and the insurance industry generally. So, focusing efforts on traditional Medicare can have returns.
Yeah, and I would also make the argument, and I think that certainly, Chris, you probably can appreciate this, but it's just across the board. Most practices don't really make money on their Medicare book of business, right? It is actually the commercial payers. In fact, in many ways, many programs subsidize their Medicare book of business from their commercial side. So there's real concern. This has been a long-standing issue. But I think, in thinking about where we go as a specialty, I think payment reform, some form of payment reform is vital. And whatever we do, it needs to provide stability, predictability, so that we can care for our patients and not be in the situation where we're at the whim of regulations from a year-to-year basis. So I think in many ways, and that's really been the focus of our efforts with working with ACRO and a number of other organizations to make sure that whatever we do, we can at least pass this phase that we've been in for the last 7 to 8 years and even longer, to something that's more predictable, that perhaps is inflation adjusted, so that we can stem the separation that Jason showed you earlier in those slides.
One of the questions that we got in our chat came from Dr. Parikh, and there are two parts of his question that I wanted to just sort of point out to the panel here. He says, a recent publication in Advances in Radiation Oncology noted that America is the world leader in hypofractionation. With self-policing and the nudge from prior auth, we've bent the cost curve more than any oncologic specialty. And so why are we still a target? And as a close follow-up to that is one other part of his question, which says, what keeps Congress from down the line reducing our per case rate? So I think both of those are worth weighing in on.
I'll take a stab at it. And in fact, two things. When I was at my former institution, we developed clinical pathways, and whether it was around breast or even prostate, we started adopting hypofractionation well ahead of, because of those regulatory pressures, authorization pressures, more so than anything else, right? Unfortunately, what we didn't do, in my view, is do it the right way, which would have been to say, we're going to start adopting hyperfractionation. Here's the data that suggests it. We're going to start bending the curve. Let's figure out some, this cost-saving, revenue-sharing process that would have done this. It's coming down the pike. Hyperfractionation is increasing. You can see it across the different disease sites. And so rather than, and I think the conversations that we've been having recently relative to payment reform is maybe moving away from this per click approach to something that sort of makes sense. It's a little bit more reasonable. But Simila is absolutely right that even if we establish a rate now, Congress legislatively, but they always have that power, right? So I think, however, if we can create something that says that over a certain period of time, whether it's 5 or 7 or 10 years, if we can at least get something that's a little bit more predictable, I think we're in a better position. But you're right, we're never going to be able to absolutely avoid, the knife if somebody wants to put it to us. But that's true for all of medicine, right?
I think also, to his point, though, it's a lot, I don't know, I suspect less likely that an elected official is going to advocate cutting radiation oncology cancer care reimbursement than a regulator, from CMS or where have you.
And just to add to that part of the conversation, I think this is why it's so important for all of us to be educated about these issues and to advocate for our patients and for our field. And that speaks to the fact that, yes, the legislation can change, but I think if our lawmakers understand what we're doing and why, they see the value of what we give to our patients, I think that would help us all. Now, there's a couple of other questions here that came through that I think are worth discussing some more. And please feel free to add more questions as we continue the conversation. We have about 9 more minutes left. This question from Samula again, I think is one that we can try to discuss briefly. If rate stabilization is a worthy goal, and if all RT costs are equal, what is the rationale for sparing proton therapy? I'm in prior auth, and this is one of the costs rising most quickly. So, I'll just, take a stab at this question and say that, there's a lot of different inputs that come into making any sort of model, and a model is just a model. In terms of, proton therapy, I'm not someone who does protons very recently. I did a few years back as part of my practice. I think there are specialized parts of what we do, like brachytherapy, like protons, more recently, like adaptive therapy that has undergone some changes. And as we put all of these different special tools that we have in our practice into a larger model, we have to make sure that it makes sense for everyone. So I think this is still an area of ongoing discussion and analysis. So I wanted to just see if there are any other questions here that people have.
Yeah, Tarita, there's a question in the chat about discussion dialogue between ASTRO and ACRO regarding ROCKR proposal. Does ACRO support the proposal in its current form?
Okay, that's from Dr. Bekta. Thank you, Dwight, for highlighting that question. So, I think that work on radiation payment reform has been an ongoing effort since before 2015, and Jason was able to provide such a great background into that. And before the 2015 bill that froze our codes, and requested a report to Congress on a radiation oncology payment, APM, this has been an ongoing dialogue. The one thing that we do know for sure is that if we're successful in convincing Congress to enact radiation oncology payment reform, it won't exactly be CMMI's RO, APM, ASTRO's ROCKR, or any previous plan. So we believe that the name is less important than the fact that we all come together as a specialty to reach a consensus on how to move forward. And that's part of the reason why we have the survey that we're doing that Dr. Wilding shared, and that why we're collaborating with ASTRO to try to move our field forward. So I think this is a really very good question. And I think that trying to work together. Go ahead, Chris.
To that end, I think, we owe a special thanks to Dr. Mance, for tremendous collaboration that we've received from ASTRO, while he was leading the charge there. And I'm sure, I think it's Dr. Yashar that's taking over. I'm sure we'll get commensurate cooperation. Their input has been tremendously useful, and for which we're grateful.
Yep. And I know we're getting to the top of the hour here, but I will also say this, that, one of the reasons why we're having this town hall and why we're having these conversations is because this does affect the entire community, right? Our entire radiation oncology community. And as a result, it affects the patients that we serve. And so one of the things that we want to do, a few of the things that we want to do, is make sure that we hear your voices. We wanted to have as much time as possible for you to ask us these really very important questions. I'm going to encourage you to not let this be the final dialogue that we have around this. If we're going to create a model that really defines things for our future, we need to make sure that it's representative of our community. That doesn't mean that we're going to all agree on everything, but at least if we can find common ground and move a process forward that creates stability and consistency and predictability, I think we're in a much better position than we are today. And I would also add that each of you on this call, it's really important. You know, there are a lot of folks, there's probably a small group of individuals doing a lot of work. We're doing a lot of work on your behalf, but I would also make the argument that you too individually can make a difference by reaching out to your congressman, by interacting with your society leaders, by being an advocate, by joining your PACs of the individual organization, contributing to those PACs as well to help us make this a reality, because this is it's a pretty big lift. But I think to get there, we're going to need your support on multiple different levels. And that's kind of what I would say is this is not insurmountable. We can do this. But I think it's going to really take a lot of effort from us as a combined community to make it happen.
Very well said, Dr. Heron. Thank you for those words. I think I agree 100%. And, all of us as stakeholders, those vendors that help support what we do for our patients, our colleagues in different practice environments, all of us are trying to do our best for our patients and for our community. So I hope that this is the start of the conversation for us with all of you. And if you guys, have any other questions, we've got about 3 minutes left. I'd also, like to have Joe or Chris or Jason add some final thoughts from us if there are no other questions. Okay, it looks like we do have a question here, so that's
the question was really for Joe, I think. Are there plans to release the survey results? And I'm going to preempt you and say yes, but I'll let you answer that in greater detail.
Absolutely. I mean, we want to get the results out there as timely as possible so it can contribute to the conversation. We also want to make sure that we don't cut the survey off while we're still receiving a good number of entries. The more representative the data can be of our field as a whole, the more confidence we can have in any consensus that it shows. So, we will be analyzing it in detail in a rigorous process and releasing it, in multiple ways. It'll be, hopefully published for all to read and kind of analyze. It'll, I imagine, be discussed at ACRO at the summit in March. And, just like any other data for, trials or other studies, that data can be available on request once it's, once the preliminary, or not preliminary at that point, but once the results are publicly available. And again, we have on our screen here, anyone who hasn't had the opportunity yet to participate, really hope that you will share your opinions with us. If you can't find the survey in your email, then please do sign up with an alternate email, and we'll make sure that, make every effort possible to get the survey to you.
Wonderful. Thank you. Thank you, Joe. So we're at the top of the hour and we have just about a minute left. If you have some questions that were not addressed, please reach out to our ACRO email, and we're happy to try to address those questions if we can. I would encourage you all to remain involved and engaged. Thank you for your time. Happy Thanksgiving, and hopefully we can continue this conversation. Thank you, everyone.
Thanks, everyone.
Thank you.
Bye.
Much.